Hello and welcome back to Corduroy, the heart of clinical care. I'm your host, Dr. Roy Ziegelstein. For today's episode, I'm excited to bring on Dr. Adam Rodman, a dear friend with a unique path that brings together history and medical education to be a leading voice in the conversations around AI and patient care. Before we introduce Dr. Rodman, we'll discuss human oversight in AI and a bit about the United States Preventive Services Task Force, and we'll explore a new segment, patient-centered care. To kick things off for this week's Tech Talk, I want to pose a question. How valuable is human oversight when it comes to artificial intelligence? Recently, a group of teenagers was riding in a Waymo driverless robotaxi, but it wasn't just any ride. It was apparently a joyride in which the teens were allegedly drinking alcohol and shooting toy guns from the car. And in this case, Waymo delivered the teenagers directly to the local police. Reportedly, a company representative monitoring the vehicle contacted the police, and the car was remotely directed to awaiting officers in a nearby parking lot. It turns out that some people reacting to the Waymo incident raised concerns about surveillance and passenger privacy. And, while this tension between surveillance and privacy may be an issue in this case, there's no controversy about the importance of human oversight over technology in other areas. For anyone listening to this podcast, clinicians or patients, how valuable is human oversight when it comes to the information provided to clinicians to help them provide outstanding health care? Dynamed is a clinical decision support resource that distinguishes itself by having expert clinicians and experts in evidence-based methodology in the loop at every step. And as editor-in-chief of Dynamed, this degree of human oversight is critical. I'd be interested to learn how important that is to you. That's all we have time for on today's Tech Talk, but I'd love to hear your perspective. Now let's move on to Policy Pulse. Recently, it was announced that the United States Preventive Services Task Force, or USPSTF, will be meeting this month for the first time since March 2025, likely with at least 8 new members. Health and Human Services Secretary Robert F. Kennedy Jr. has exerted significant influence over the USPSTF, firing the panel's chairs, leaving unfilled vacancies on the panel when members' terms expired, and canceling several meetings of the panel, which usually meets 3 times a year to provide evidence-based recommendations intended to influence how clinicians practice and the coverage that health insurance companies provide for certain clinical practices and procedures. So what does this all mean? The USPSTF was convened in 1984 by the United States Department of Health and Human Services, and its volunteer members are appointed by the U.S. Department of Health and Human Services Secretary. The purpose of the task force, as stated on its website, is, quote, to improve the health of people nationwide by making evidence-based recommendations on effective ways to prevent disease and prolong life. But the USPSTF has not been without controversy, and its findings and recommendations sometimes seem as confusing to the public as the United States Supreme Court decisions do. To me, that's because both bodies base their findings on interpretations, and interpretations may vary based on the times and based on the members of the court, or in this case, the members of the task force. And in the case of the USPSTF, the evidence itself changes over time. Let's take breast cancer and screening mammography as an example. Most recently in 2024, the USPSTF recommended that women undergo screening mammography every 2 years, beginning at age 40 until age 74. That changed the existing task force recommendations on the topic and actually seemed to go back to recommendations the task force made more than 20 years ago. And that back and forth bothers some people. But you know what? I get it. Evidence changes. The accuracy of screening tests change. The treatment of conditions detected early in their course changes. Recommendations themselves, of course, should change. That's not the question, or at least not to me. The question to me is how evidence is evaluated and who evaluates it. As editor-in-chief of Dynamed, an evidence-based clinical decision support tool, you better believe that's important to me. And with respect to scientific and medical evidence and the USPSTF, the question is, how much control should the government extend in deciding the how and the who? What are your thoughts? That's it for today's Policy Pulse. As always, I'll be watching how these policies take shape, but I'd love to know what you're watching as well. Like many of you listening, I got into medicine to make an impact and help patients. And that's why we're introducing this segment called Patient-Centered Care, to remind ourselves of key actions we can take to bring our practice back to the patient. For today's discussion, I want to talk about a trend that caught my attention recently, which comes from the Bureau of Labor Statistics American Time Use Survey, which measures how Americans spend time on daily activities, including work, caregiving, leisure time, and socializing. According to the latest data, people were less likely to engage in socializing and communicating on an average day in 2025. It was 30%. Than they were in 2015. At that time, it was 38%. They also spent less time doing so, 35 minutes a day in 2025 compared to 41 minutes in 2015. Now, this may sound like a culture shift, but I see it as a health warning. Social connection is not separate from health. In fact, the American Heart Association has noted that social isolation and loneliness are associated with worse heart and brain health, including an increased risk of heart attack and stroke. I'm sure that clinicians already ask their patients about diet and exercise, and if they haven't already started asking patients about their social connections, family, friends, faith and community organizations, they should. This is really critical to getting to know the patient as a person in order to understand their health, something I've called personomics. My guess is that you listen to podcasts alone. In fact, most people do. But why not tell a friend about it? Have that person listen and then start a podcast club instead of a book club. And what better way to start than by talking about corduroy? One last thing. The National Academy of Medicine recently selected 10 individuals for the 2026 class of their Scholars in Diagnostic Excellence program, a program for outstanding scholars in clinical diagnosis to, quote, accelerate their career development as national leaders in the field. This is a major honor, and I'm delighted to share that Dr. Adam Rodman, this month's Corduroy podcast guest, was one of the 10 individuals chosen to participate in this prestigious program. And now, my interview with Dr. Adam Rodman, so you can learn why he received this extraordinary honor. I'm really delighted today to introduce Adam Rodman as my guest on the podcast. You know, Adam is really well known in the area of AI and clinical decisions. I think probably many people know him. And rather than giving a long introduction, Adam, I'm wondering if you might say just a few words about yourself and sort of what's interesting about you. Why should people want to listen to this podcast?
Well, great to see you, Roy. What's interesting about me? I'm a remarkably strange person, but I'll do this for my spiel on what's interesting. So I'm the strangest artificial intelligence researcher you'll ever meet because I got into AI research by being a historian, right? So what I specialized in was the epistemological nature of diagnosis, how doctors make decisions about what diseases or what even is a disease, and how we approach and structure that knowledge. I had a podcast, Bedside Rounds, which is basically about the intellectual underpinnings of how modern medicine came to be. I wrote a book, and I was working on this book on sort of like, especially in the 19th and 20th century, on diagnosis. I was talking for the book, interviewing a bunch of famous informaticists, a lot of people in this sort of first generation in the 60s, 70s, and 80s who thought that the computers were about to replace us. One of my fun claims to fame is I believe the last chapter of my book, I try to predict the future, and I'm like, man, natural language processing, a lot of these ML classification technologies, even language models are exciting, but it's going to be a decade more. The book was published 1 month before ChatGPT came out because that's how long it takes to publish books. So that's my kind of fun fact. Like, I became an AI researcher because I'm obsessed with this sort of historical trend of how doctors make decisions and what it means to make a decision and how technology changes that.
Well, that's great. I mean, Adam, I think you drew me in, and I hope you drew in everyone into the podcast. So I know that you and I met a couple of years ago when you gave grand rounds, and I was the guinea pig. I agreed to be the so-called expert diagnostician going up against AI to solve a clinical problem. Now, I'm not going to tell anyone who won in that contest, but there's no doubt that I was the ultimate winner because as a result of that interaction, I had the opportunity to meet you. So, with that initial interaction in mind, do you view AI as a human versus or a human and? Is AI a friend or a foe?
Well, I think that's a I'm going to get very historical here, talking about Jacques Derrida and the concept of a pharmacon from Plato's Pharmacy. So Derrida and many of the post-structuralist philosophers would argue that technology is neither a friend nor a foe, and this comes from this Greek idea that the same word for medicine and poison, it's the same word, and merely how you use it and the dose in which you use it. So I think a lot of the discourse about artificial intelligence, and in this case, just to be explicit, we're talking about like language models, things that can, or language models and similar transformer powered technologies that can have human like thought processes. And I do not think a priori that they are either a friend or foe, but rather a tool that we can hopefully use to make our patients better. I think to what you're getting at is doctors do not need to be worried about imminent replacement. There is a lot of hype out there about us, like, why do we need doctors? And there's a lot of tech startups with frothy Series A's who, they'll raise more money than I'll make as a doctor in my entire career selling this idea of an AI doctor. And I don't think that is something that is realistic on this class of technology. So not something doctors need to worry about. But the friend or foe is complicated. And I think, it depends. I'm doing air quotes.
Yeah, I think that's really, I mean, from my perspective, totally on point. I mean, like any tool, right? I mean, if you said to me, could I use my stethoscope to screw in a screw? No. And in that regard, it's not very useful. It really depends on how you use the tool. So let me shift a little bit and talk about not just your background as a historian, but your background as a medical educator, because that's pretty significant. And it turns out that a lot of physicians and clinicians in general who focus on AI are actually clinical informaticists. And they have a background in engineering, tech, computer science. But you really have a very different background, not just because of your expertise and background in history, but also med ed. So if that's the case, how do you think that perspective, not the history part necessarily, but the medical education, might have helped you to get a different perspective on AI in medical training?
That's a really good question. So, yes, that's very perceptive. I think if you look at my background and what makes me somewhat unique in this field is that I'm not coming from a computational background. I work with computational people all the time, great respect for what they do. But what I'm coming with is this more educational background. And we might even say like psychological background, because what I'm obsessed with is how people think and how we can measure how technology, or not just technology, how anything changes those thinking processes. So in a lot of my work, uh, I have focused on what you might call, say, robo-psychology, which is using techniques we use to understand how humans make decisions, to understand how LLMs or AI systems are making decisions and their failure points. But even more frequently, this is what I just did in my the clinical trial that we just pre-printed, is that I'm using a lot of that educational background to understand the human-computer interaction. As you say, like, it's a tool. I think it is definitely a tool right now, and what matters is optimizing, like, obviously, you can make the tool itself better at what it does, but really optimizing that interaction. And, as a medical educator, I spend a lot of time thinking about this, and I'm sure we're gonna talk about this a little bit more in depth, is that one of the downstream effects of these very powerful tools is that they cause some degree of cognitive offloading. That is, the tools, one of the reasons they are powerful is that they can make human-like decisions, and if they can make human-like decisions, you don't need to use your own thinking to do that. So there is a widespread concern in medical education that the tools might lead to de-skilling, which I think there's no question that they'll lead to de-skilling. There's always de-skilling with new technologies, but even more concerningly, some never skilling, right? A world in which we don't have our trainees gaining the abilities that we have, which we got because, my hair's gray. Like, we went through a world where we just had to mess up a lot under supervision and get feedback, which is the time-honored way to train a physician, and some of that may be changing.
Yeah, well, let me ask you a follow-up question to that because I think that's very interesting. It's kind of a leading question.
I
I'm
love
not gonna
this.
I'm not gonna tip my hand here, but one of the things that I did when I was vice dean for education was in the beginning of the first year, I taught the students, I introduced them, shall we say, to their stethoscope. Simple things like you put them in your ears and you angle them in this way.
You don't put them backwards, right? That's always
Exactly.
frustrating.
And
Takes a
by the
while.
way, if you're not hearing anything, it either might be because they're not in your ears or because you have the wrong side, and things like that. But I think we really haven't done the same. I guess I am tipping my hand with AI. Do you think in 2026, have we let our medical students and other health professions students down?
Have we let? Oh, that is a leading question. I'm going to defend.
I told you I was going to ask you a
Well,
leading question.
This is so. I am a medical educator at Harvard. I lead the steering group to figure out what we're going to do. And so I don't want to. Obviously, I'm going to sound defensive from the beginning. I think the stethoscope is a good example, right? Because René Laennec invented the stethoscope in 1816, and in the 1890s, doctors were still arguing about how useful the stethoscope was. So we had a world in which the adoption of the stethoscope took generations. It took a really, really long time. And meanwhile, like, all these ideas around what does it mean to examine someone, what does it mean to do physical diagnosis, those evolved at the same time. That is so different. Like, ChatGPT didn't exist in November. Well, it started to exist for everybody in November of 2023. And now every single medical resident uses open evidence to make every single decision. So we have a world, like, medicine is conservative, and I think it's often appropriately so, right? We have really high stakes to how we train people and the decisions we make. We make life and death decisions. But I just think that it's changing so quickly that an example like the stethoscope, like, those doctors had 100 years to figure that out, and then the stethoscope changed, obviously, but not that much. And these models are changing all the time. So yes, we of course are doing a disservice. But I also think, with sympathy to the educators, I know as much as anybody, and I don't know what to teach them. All I know is that the future is going to look very different than it does right now.
Yeah. I mean, look, the truth is, back when Laennec invented the stethoscope, many teachers had no idea how to use a stethoscope. And I think we're sort of in that area now with AI. Let me just ask you about the different types of AI clinical decision support tools available, not necessarily specific names, but you know how they say sometimes if you've seen one patient with such and such, you've seen one patient with such and such?
Yeah.
I think if you've seen one AI clinical decision support tool, you've seen one AI clinical decision support tool. So my question is, how do you think clinicians and or medical educators can judge the trustworthiness of AI clinical decision support tools? And is there anything that a tool could provide clinicians that should allow clinicians to accept a lower level of trust?
You're asking some Easy questions here. Yeah, so CDS, clinical decision support, is actually quite an old term. It was invented in the 1970s by Tim de Dombal. And one of the problems is clinical decision support. As you say, you've seen one, you've seen one. Both the phrase AI and clinical decision support don't really mean anything, right? There's this fun history in AI. AI has been around for a long time. Like ideas of cybernetics actually predate the phrase AI. So like when de Dombal invented the term clinical decision support, AI was a naive Bayesian algorithm. It was like the Wells score, right? So it was what none of us would consider AI right now, or it was an expert system, so like the ACLS algorithm. So when it comes to like AI tools, there's just so many types and they all work very differently. A Bayesian algorithm is AI, expert system is AI, a machine learning classification, like an image classification system, like a convolutional neural network, which used in radiology all the time, or like in pulp detection, that's AI. A large language model that stochastically generates a recommendation is AI. And the problem of why this is so hard to teach is that all of those systems they're technologically related, but they have different failure modes. They behave differently out of distribution, right? They'll fail in different sorts of ways, and they have different levels. And this is what you're getting at, Roy, what we call interpretability, our ability to understand them. So, for example, a Bayesian algorithm, you can actually look at all the pieces. Like maybe the pretest probability was wrong. Maybe the sample was weighted differently, or the population wasn't representative. You can go back and look at that. An expert system, very easy to say, oh, this chain of thought was wrong. When you get to something like a convolutional neural network, well, it's so complex. You can't interrogate going way back. What you can do is say, okay, well, maybe this was the area that the model was paying attention to. You can do these things called heat maps, but it's not really telling you what they think or whether it's right or wrong. And then you get to language models. My God. And language models, they're huge. Some of the labs do interpretability work, but you really have no way of knowing what a language model says. And we know, so there's this idea that maybe you can understand the interpretability by looking at, for these reasoners, by what's called the chain of thought. So looking at how they think, because when they will write their thoughts in usually a hidden file and you can see what they think. But we also know that like those are not accurate. Those are not actually representing what happens. In the prospective clinical trial that I recently ran, we actually did an investigation looking at the reasoning traces as they had conversations with patients who were seeking urgent care. And all of the models were very convincing and got more confident as time went on. And it had nothing to do with whether they were right or wrong. So this is like, it's so hard to teach because there's many different types of technologies. And a lot of what we talk about interpretability or thinking about this is pseudo interpretability. It's the appearance of understanding why they're wrong. And it's not clear that that even helps like us understand. So I understand why people are frustrated.
Yeah, thanks for that answer. I usually don't offer my opinion on top of a guest, but I'm gonna
Please
say
do.
no. I'm gonna say I agree 100%. If you've seen one, you've seen one. I think there are huge differences among the tools available. Some of what I would call health specific tools, and others that are not necessarily specific to health in terms of their trustworthiness and the type of answers they give. And here's the problem from my perspective in terms of going back now to medical education. A seasoned, really experienced, incredibly intelligent clinician like you, yes, I'm flattering you.
I'll take it.
You can tell the difference between kind of gibberish response and high quality, trustworthy response. But a learner, an early learner, may not be able to know the difference, and that is where danger actually might exist, especially if they actually are in a position to make treatment decisions based on what amounts to gibberish. But my next question and final question.
Oh, I'm ready.
Adam, final question. You kind of got around my question about friend or foe. You did a beautiful job kind of getting around that.
A beautiful job of not answering your question.
You did a nice job.
But had some media training.
You did beautifully, but I have another question that you're not going to be able to get around, okay? The next decade of AI in healthcare, the next decade of technology in healthcare, optimistic or pessimistic?
So yeah, I actually am optimistic because I am trying to push for I'm trying to advocate and do research towards a better world. Like I'll tell you what I'm worried about, which is that AI is not it's not magical. LLMs are not magical. And if you put them on a system that does not take advantage of them, you will find negative externalities. I mean, even like AI scribes. I know people like AI scribes. So far, they haven't had a major impact. The randomized controlled trials don't suggest much time savings. But let's think this out to its logical conclusion. If there are time savings, you're just going to see more patients. So, meaning from the patient perspective, you'll have even less time with your doctor. And it's not necessarily going to lead into a system that makes us happier. The same thing, if you think about scalable oversight, I'm very excited about the abilities, and a lot of my research is identifying errors before they happen. Well, that same technology, if deployed in our current revenue maximizing system, instead of identifying errors, could identify, hey, Adam, this person really has severe protein calorie malnutrition. Did you document all these comorbidities? And could really degrade my own experience, even though I would love for this technology to be like looking for places that I could be wrong and implementing early. So I'm optimistic, I think, because I have some agency in this and because I'm a researcher and I'm trying to push the field in a certain direction. What I have seen so far is that we're just recreating all the same problems we had with the electronic health record. So I from a research perspective, and again, I think from a regulatory perspective, I think there is a understanding among like people in the government that things need to change. But what I've seen in terms of like deployments does not fill me with hope, even though I am optimistic overall.
Thanks, Adam. And I'll just say I'm kind of jealous of the young people today for a lot of different reasons, but mostly because I'm very optimistic about the future of healthcare and the ability to use technology to the better for better patient care. Let me just say that I want to go on record and say that that initial meeting that you and I had, where it was Roy Ziegelstein versus AI in a
It was just like
clinical.
2 years ago, wasn't it? It was very recent.
It was. I want to go on the record and say it did not occur in Las Vegas. However, what happens in Vegas stays in Vegas, and so I'm so glad that you did not let people know who won. And I'm so glad that you joined us today for what was really an incredible and really, really interesting podcast. Again, thank you, Adam, for all of your insight and for answering my questions.
Thank you for having me, Roy. This was a lot of fun.
That brings us to the end of our episode today. Adam, thank you so much for joining me and for sharing your points of view on where we're heading when it comes to introducing AI into care settings. New episodes will be released on the first Tuesday of every month, so please stay tuned and be sure to like and subscribe to get notified, and connect with me on LinkedIn. I'd love to continue the conversation. Until next time, stay true to the core.